Hi, greetings. Communication lesson continues. I would like to present before you a chapter prepared by Colonel Dr. Yashwant Joshi, National Vice President, Awareness and Advocacy, National Association of Palliative Care for Ayush and Integrative Medicine, on communication in palliative care. This is a patient admitted in a palliative care center, and doctor is examines the patient, and this is the photograph. The caregiver is standing close to the bed. So this is a situation. A patient undergoes some traumatic problems, and let's see how communication plays in this regard. As I said in the earlier presentation, touch is an important communication tool in the hands of the palliative care professional. This is a diagrammatic representation of how a patient feels. So, what would be the helplessness, the stage of helplessness that a patient feels when he is afflicted with an end-stage disease. So, this is a representation of a doctor, this is a representation of the patient. Whatever the doctor says is the Bible of the patient at that point of time, because the patient is at the mercy of the doctor at this point of time, because he is helpless, he does not know what to do, what is the future of his family, his children's education, his own future will be very deplorable condition, and he feels that whatever the doctor can say, I will take it for granted, because I hope that whatever the doctor says will save me from this suffering. How doctors communicate? I do not intend to undermine the efficacy of the professionals, doctor professionals, but in certain situations we come across a similar pattern of communication that the doctor fraternity used to follow. Doctor at a public hospital, we are all at the mercy of the public hospital or the government hospital when we do not have enough money with us to go to a private hospital. So, it is at his mercy that we go there for consultation, and he says that no, nothing can be done, you can take the patient back home. So, that is the what you call the texture of the communication that the doctor is usually making. What about a doctor at a private hospital? He is there to get money. Money is the most important ingredient for the survival of the hospital. So, what he says would be like this: you see, nothing can be done at this juncture, but anyway we will try. Okay. The tone, the intonation is different what we see in our daily life. So, I do not again I am saying that I do not undermine the efficacy and the competency of the doctor professionals. Please refer Mastering Communication with Seriously Ill Patients. This is a book written by 3 people, Anthony Beck, Robert Arnold and James Tulsky. Another book is Communication in Palliative Care by Janet Dunphy. So, if you happen to come across this book, please go through it, you will get a better idea of how palliative care communication is made. Well, yes, I suppose I could explain the test results in plain English, but then you would know how sick you are. You know, while saying a thing, the underneath meaning may differ from person to person. Until that time, the patient may not be aware of the seriousness of the disease, but when the doctor is about to tell or when he tells that you are having a very irreversible disease, then the whole thing will go upside down. This is a diagrammatic representation of what would be the result of a doctor telling the truth to the patient. So, there are a lot of things we should take into account before conveying a difficult message to the patient who is already spoiled by his own body weaknesses, his own funds, his own personal stature and social stature and all that. So, he is undergoing a very traumatic situation, and the doctor should understand the particular situation, then only he should convey the message in a polite and understanding way. So, in palliative care, the focus is on the person with the disease. There are two types. We are all human beings, we are all persons, but the patient is a person with a disease. That is a difference. We do not have any disease at this point of time, we are persons, and the patient is also a person, but the only difference is that we do not have anything any disease at this point. The patient has a disease. So, the patient is a person with the disease rather than the disease. Therefore, communication is very important in palliative care. Treating patient and family as unit of care, recognizing psychological and spiritual needs. Here the photo shows husband is weak, he is a person with a disease, she is his wife. So, she is trying to give injections. So, possibly the doctor must have given the method of injecting that particular medicine. So, what are the consequences of poor communication or what we call bad communication? There are 7 steps, what we call DABDA theory, we call it DABDA theory. So, when you learn about the truth of the disease, then the first thing you are likely to have is shock, because until that period, until that time, you are not aware that you are undergoing a treatment for a disease which is irreversible. When the doctor says that you have got an irreversible disease and you are not going to be treated and you cannot come back to your life. So, at that point of time, every human being undergoes a state of shock. Then there will be some emotional consequences, that for some time the patient may not be able to speak anything at all. He will go to dumbness, we call it. We all experience it in our day-to-day life. Then there will be a bargaining, that no, I am not supposed to have this type of disease. My disease is curable, treatable, and I will come back to my life. So, you deny after shock, the emotional consequences, that is numbness. You start denying things. No, I do not have this. The doctor says the result is not correct. Something is wrong with the doctor, something is wrong with the result, the examination process is not correct. We will find all types of negativities, or no. So, that is denial. That is the second stage of receiving, after receiving a communication that we do not like to have. Then comes anger. So, over a period of time, when that denial process persists, you switch over to the next stage, that is anger. When you are having any sort of a pain, you will have anger. When somebody is angry, we should understand that he has some pain, either maybe in his body or in his mind. There are different levels of pain, physical pain, psychological pain, emotional pains, we call it different languages. So, pain is a reason for a person to be angry. You can check with yourself, your relatives, your relatives, your close friends and all that. When somebody is getting angry, you can ask him, do you have any pain somewhere in your body or in mind? So, pain is the reason for anger. Anxiety. So, that stage goes and he goes to the next stage, anxiety. What will happen to me? What will happen to me? Anyway, the doctor says that my disease is incurable, I am incurable, I am untreatable. What can I, how can I prolong my life? Whether I can go to the office, whether I have employment, what will be the fate of my family, what will be the fate of my children going for studies and all that, what will be the future of the whole family. So, he will build up anxiety, that is the next stage. Then the next stage, anxiety goes on for a maybe for a long duration. He will have all sorts of questions for which he does not find any answers. So, the next stage is depression. All these stages we in our daily life undergo. This is not a new thing, but we take very important this thing, understanding of these 7 stages in our palliative care activities when we confront with a patient who is having a disease, a person with a disease. So, depression is the next stage. You will be depressed, psychologically and emotionally you will become weak. You may have to be consulted for depression. So, that is the next stage, and at last you will find that what the doctor has said may be true. It may be because of some bad things I had done in my early life or during my past life. That may be the thing, or that may be the reason why I am put in such state. So, depression gives way to guilt. Then is the actual approval. You accept it. That is the next step. 1, 2, 3, 4, 5, 6, 7, 8. There is another step that we call acceptance. So, these are the levels of the mind that undergoes when we receive a poor communication or a bad communication. Next is problems in communication. During the last slide, we came across the different stages of grief. Now, problems in communication may be fright of upsetting the patient. As we saw, fright, the patient is at shock, anxious about doing more harm than good. He is anxiety, that was one stage. Ill-equipped to answer difficult questions, ill-equipped to give answer difficult questions. You have a lot of questions, you are questioning yourself and you may not be able to find suitable answers. Short of time, all this come within a short while, it will not take more than 1 day or 2 days or so, maybe some hours, when the bad communication is conveyed to the patient by the doctor or the appropriate person. So, there may be a short of time. You will have to get things done within the short span of time, because you are now fully aware that nothing can help me at this belated hour. So, I have to plan many things before I die, unable to handle the patient's emotions. So, we will have to give the patient sufficient time to ventilate his emotions, that we call it, ventilate the emotions. We cannot make the situation better, we cannot cure the patient. If we are unable to give him sufficient time to ventilate his grievances, ventilate his a lot of problems, issues, past things he had done, he may be repenting what all bad things he had done, a lot of things are coming in. So, we should give sufficient time to the patient to make this to encounter this particular situation. Then only we will be able to mentally prepare the patient to face death. This is class protocol. What is class protocol? Class protocol are the best practices for healthcare communications. Physical context or setting, that is C. context. As we saw earlier, context in the sense you remove all the physical barriers, the mental barriers and all barriers. Have eye to eye contact and sit close to the patient. You must have touch with the patient. So, these are all context. Listening skills. You should have a presence of mind to listen what the patient wants to say to you, convey to you, communicate to you, and acknowledge emotions and explore them. Whenever you see a message, you can ask a question or keep a note, yes, I understand it, so that the patient may feel that I am here to help you. So, that is the message that we have to convey while communicating with the patient. Management strategy. The patient may have a lot of things to be done before he goes, before he dies. So, he will ask, what can I do at this juncture, can you please help me? So, what all things can be done by me? Maybe there may be unfinished portion of his house, he wants the thatch to be put right. So, he wants to make the completion of the studies of his children. His wife is not medically fit, so she wants to undergo some surgery during these days. So, many things, financial stringency, financial problems, all these things will come into the picture, and we may not be able to comply with or satisfy all their needs, but we can find certain things, solutions to certain things. So, what that is management strategy and summary and closure. So, finally, we had to share our output to the patient that these things are the problems with you, understand it. I can interfere in these things and I will interact with the concerned people and see that something better can be done to make sure that you have a very, very peaceful death. So, this is class protocol. For effective communication is already explained. 6-point toolkit: comfort, language, question style, active listening, reflecting and summarizing. Be prepared to stop the interview at any stage, that is important. Sometimes the patient may not feel that he wants to, he does not like to continue the interview with the doctor or the person. So, the patient is likely to say, you see, I am feeling drowsy, I want to sleep. We can continue the discussion later. Okay, we should stop the interview at that stage. No, that is not the thing. We can continue and finish up the thing so that we can take decision. No, that is not the way palliative care intends to do on a patient. So, whenever the patient says we have to stop this interview at this point, we are supposed to stop it abruptly, we have to stop the interview. For repetition of questions, so be prepared to repeat some questions, because as a way of clarification and not to disturb the patient in any manner. So, as by way of a repetition of a question, we are seeking a clarity on certain questions which the patient shared with you. For silence, sometimes you may not have any answers to any of the questions or some of the questions that the patient wants you to have. So, keep silent, then the patient will understand that you are not equipped with a suitable answer. So, he will switch over to the next questions. For denial, in certain things the interviewer may have to deny the suggestion or the advice or the comment that is made by the patient. Say for example, the patient says that, you see, the services of your palliative care department is very poor. Sometimes it may not be so, but you have to deny if it is not so and explain to him that this is a situation under which such a thing happened and we will take care of it not to have recurrence in the future. For emotional reactions, these are something which the interviewer has to be prepared to undergo. Comfort, preparation, physical environment, sitting, perception of time spent, height of chairs, eye contact. Except height of chairs, everything is explained. Height of chairs means usually when you go for consultation to a doctor, the doctor sits on a big revolving chair. The patient sits on a stool on the side, isn't it? That is a general thing we happen to come across when we go to a hospital. So, in palliative care it is not so. The doctor or the interviewer or the person who visits and the patient sit on similar height, then only we can establish commonness. Otherwise, the patient may feel that this doctor is a very big fellow, whatever I say, how will he take it and all that. So, we will make an impression, we will create an impression that the patient and the doctor are at par, are on the same level. That is height of contact. The rest of the thing we have already discussed. Common ways of distancing: non-verbal messages, labeling, categorizing, paying selective attention to say physical aspects, never asking beyond the physical, using only closed questions. These are all common ways of distancing. Premature normalization, false reassurance, using euphemisms to mislead, jollying along, concentrating on physical tasks, inappropriate humor, disappearing from the stressful situations. So, many of the things we had discussed earlier, non-verbal messages. So, your body language should not give an impression that you are distancing the patient or you want to have a distance with the patient. Labeling, categorizing, that you are a doctor and he is a patient. So, do not put it in that way, we are common people. Paying selective attention to safe physical aspects. Those things which you have answers, do not ask such questions. You can ask any question, whether the patient knows it or the patient can ask any questions. He should not categorize the questions. Never asking beyond the physical, using only closed questions. This is also a distancing behavior. Premature normalization. Before completing the interview, the interviewer or the doctor or the visitor says, okay, we can stop the conversation at this point. Do not say like that. This is a form of distancing behavior. False reassurance. So, give assurance to only those things which you can work on. Do not give false reassurance. Okay, you will come back to normalcy, may not be true. So, do not give false assurance. Using euphemisms to mislead, jollying along, the patient is in a very bad shape, is not in a position to receive humors. So, do not jolly along with the patient. Concentrating on physical tasks, inappropriate humor. When the family is undergoing a traumatic situation, do not put any humor. You may be under the impression that humor will give some sort of relief. It is not so. When somebody is in utter danger, can humor suffer? Will humor make any difference? Nothing. No. Disappearing from stressful situations. Some people are like that. Now, when you are unable to cope with a particular situation, they slowly disappear from the scene because you are unable to do anything at all. So, these are all common ways of distancing, or we call it distancing behavior. This is a case history. The word history is coined his story. We need to know his issues in order to help him. Listen to the story. Active listening is the key to effective communication. Open questions, encourage talking, accept silence, allow assimilation of news, patient feels listened to, time to react, ask questions, talk, avoid unnecessary interruption, respond through verbal and non-verbal means, summarize and prioritize the agenda, empathize and give realistic hope. Next is eye contact. Listen, listen, listen. The ears are there to listen to the eyes are there to look to. So, undivided attention is the hallmark of palliative care. So, listen, listen, listen. Active listening. Note to show you are paying attention. Repeat words of patient to encourage. Pick up cues. Reflect questions back. Ask about feelings. Validate feelings. Watch body language and pick up non-verbal cues. Summarize details of conversation. Prioritize problems. For example, what have you been told about your illness so far? We can ask the patient what the doctor said about the disease or the illness that you are suffering from, or what is your understanding of the reasons we did the scan. So, we did a scan recently. So, what do you think, why we took a scan at this point? The responses to such questions will indicate the patient's understanding of his or her illness to date, will allow for the correction of misinformation and can also help to determine whether or not the patient has, for example, unrealistic expectations, illness denial or gaps in information about his or her illness. So, reflecting on answers. Summarizing. Present treatment or palliative care options, being sure to align your information with what you ascertained during the assessment of the patient's perceptions to be the patient's knowledge, expectations and hopes. Providing a clear strategy will lessen the patient's anxiety and uncertainty. So, there are different ways of communicating, there are different communication skills. So, some of them are explained here. Kind and concerned as a painful duty, beating around the bush, jargon, disguised hints, leaving the patient confused, depressed, resentful. So, that is not advisable. Hit and run approach, leaving a shattered patient, that is also not beneficial to the patient, and do not follow that. Blunt and unfeeling, straight answer to straight questions, leaving an unprepared patient without support, worried and depressed. So, do not do that. The don'ts in communication. Talking to the relative only, leaving the patient suspicious and worried, do not do it. Whenever you speak to the carer, try to speak to the patient if possible, if he is not sleeping or otherwise engaged. That will give you see, otherwise that will leave the patient suspicious and worried about what you have been telling each other to my my carer and all that. So, that will create misunderstanding in the minds of the patient. Flexible, based on feedback with reassurance, leaving the patient concerned but are reassured, based on feedback with the reassurance. So, you will say that you will be all right soon. So, you leave the place and all. These are all things which you do not follow, you do not take care or you do not do. So, these are the don'ts in communication. Empathy. What do you understand by the term empathy? Give some examples of when you as a nurse were empathetic with a patient. How did you feel when you were able to identify with that patient and make a real difference to his or her situation? Understanding the words. There are certain pathis, as I told you earlier. Apathy means disinterest. Pity, I pity, what we call, you see, you fell down, isn't it? Oh, I pity you. Sympathy, you fell down. Okay, what happened to you? Finished. Empathy is something different. Keep ourselves in other shoes, as we usually put. So, we want to be experiencing in the other man's heart or other man's situation. So, compassion is a level up. You see, I understand your situation, I am there to help you and you really help him. So, that is compassion. Apathy, lack of interest without feelings. Pity, feelings of sorrow caused by the sufferings of others. Sympathy means you can understand what the person is feeling. Empathy means that you feel what a person is feeling. Compassion is the willingness to relieve the suffering of another. These are the gradations or the different levels of understanding. This is a hierarchy of spiritual intelligence: apathy, sympathy, empathy and compassion. You should have a compassion, you should have a heart with compassion, just to help the other who is in dire need of your help and support. Understanding the words apathy, empathy, sympathy, when you are in distress, when you are distressed, there is nobody to help you, and we sympathize and we make a distancing behavior. We did not see that. Okay. By somebody who understands it, he empathizes it, and somebody who is there to help you out, he has compassion. Thank you.